Hey, it's your friend here from Book Podcaster.
Hmm.
Just wanted to send a little lifeline your way if your brain feels like it's juggling flaming chainsaws. You know that pre-exam feeling
Yeah, yeah.
where everything important you ever learned has suddenly decided to, like, take a vacation in the Bahamas.
I'm there.
Right. Okay, take a deep breath. We're going to untangle a really vital area for anyone going into healthcare, understanding and treating trauma.
Hmm.
Think of this as getting the Cliff's Notes, maybe, but with a lot more aha moments and way less chance of academic probation, hopefully.
That's the spirit. We're taking a good, solid look at the chapter on trauma and stressor-related disorders.
Mhm.
And our goal isn't just to define terms, it's to really get a feel for what's happening psychologically after someone experiences a truly impactful event.
Yeah,
These aren't your run-of-the-mill bad days. These are experiences that can fundamentally shift how someone perceives themselves and the world around them.
exactly. And what makes these disorders so distinct is that clear thread, right?
Yeah.
You
Yeah.
can trace it back to a specific event, whether it's something intensely personal like an assault or uh, something broader like surviving a natural disaster.
Right.
It's not just some vague sense of unease. There's a very real before and a profoundly different after.
And what's truly crucial, especially for those of you heading into nursing, is understanding not just the what, but the how. How trauma impacts individuals, and importantly, how your role can be pivotal in their journey toward healing.
Mhm.
We want to move beyond just recognizing the labels and really grasp the human experience behind them.
Okay, let's unpack this a bit then. When we say trauma, I mean, it's a word that gets thrown around a lot. What's a helpful way to define it in this context?
Well, Townsend offers a really concise and I think powerful definition. It's an overwhelming emotional response to a terrifying event,
Okay.
one that threatens a person's sense of physical safety or their psychological integrity. It's that feeling of being completely and utterly beyond your capacity to cope in that moment.
That really hits home. So it's not just about the objective severity, maybe, of what happened, but about that intense feeling of being overwhelmed.
Precisely.
Can you give us a clearer picture of the kinds of events that can trigger these kinds of overwhelming responses and potentially lead to these disorders?
Certainly. We're talking about a range of deeply distressing experiences. Things like physical or sexual assault, the intense and prolonged stress of combat exposure,
Right.
surviving events like hurricanes, floods, or earthquakes, being involved in or witnessing a serious car accident, seeing violence inflicted on others.
Yeah.
And the often invisible but profoundly damaging effects of abuse or neglect during childhood, these are all events that can really disrupt a person's foundational sense of safety and security.
It's a tough list,
Yeah.
and it definitely underscores how varied traumatic experiences can be. Now, when we look at the DSM-5, what are some of the specific disorders that fall into this category, these trauma and stressor-related disorders?
Within this category, we see a few key disorders. Post-traumatic stress disorder, or PTSD, that's probably the most well-known one.
Okay,
Then there's acute stress disorder, or ASD. As we'll discuss, it shares many similarities with PTSD but has a different time frame.
got it.
We also have adjustment disorders, which can pop up in response to more maybe common stressors, but still significantly impact daily life. And finally, specific to early childhood experiences, we have reactive attachment disorder and disinhibited social engagement disorder.
Okay, let's really focus on PTSD for a moment.
Mm.
It often feels like the central point of reference when we talk about the psychological impact of trauma. What are the core groups of symptoms that characterize PTSD?
Right. PTSD symptoms generally cluster into four main areas. The first is intrusion. This involves the re-experiencing of the traumatic event.
Re-experiencing. How does that show up?
Well, it's not just fleeting thoughts. It can manifest as vivid flashbacks where the person feels like they're right back in the traumatic situation. Or distressing nightmares that replay the event, or related themes or intrusive thoughts that just pop into their mind despite their efforts to, push them away. It's like the brain gets stuck on repeat.
It sounds incredibly destabilizing, like your own mind becomes a source of fear almost.
Absolutely. The second cluster is avoidance. This is where the individual actively tries to avoid anything that might trigger memories of the trauma.
Okay.
So this can include avoiding specific places, people, activities, or even internal reminders like thoughts or feelings associated with the event. It's really an attempt to create distance from the pain.
So it's almost like their world shrinks as they try to navigate it without bumping into these triggers.
Precisely. The third area involves negative alterations in cognition and mood.
Okay, what does that look like?
This can show up as feeling emotionally numb, experiencing persistent negative emotions like guilt, shame, or fear, feeling detached from others from activities they once enjoyed,
Hmm.
or even having difficulty remembering key aspects of the traumatic event. Their whole outlook can become quite negative.
That sense of detachment sounds profoundly lonely.
It often is. And finally, we have hyperarousal. This is a state of heightened alertness and reactivity.
Like being jumpy.
Yeah, exactly. It can include difficulties falling or staying asleep, increased irritability or maybe angry outbursts, an exaggerated startle response where even a small unexpected noise causes a big reaction, and hypervigilance.
Hypervigilance.
Yeah.
Like always scanning.
Yes, a constant state of scanning the environment for potential threats. It's like being constantly on edge, waiting for the other shoe to drop.
You mentioned Marcus, the veteran, earlier, and his reaction to fireworks.
Yeah.
How does his experience illustrate some of these PTSD symptoms in a really clear way?
Right. Marcus's immediate reaction to the sound of fireworks actually diving for cover is a powerful example of re-experiencing the trauma, probably through an exaggerated startle response linked to his combat experiences.
Yeah, that's intense.
And his avoidance of crowded places like festivals or markets, and that general sense of being easily startled and on edge that his family noticed, those are both manifestations of hyperarousal. It really paints a vivid picture of how these symptoms can impact daily life.
It really does. Now let's circle back to acute stress disorder, ASD. It sounds very similar to PTSD. What's the key distinction we need to understand?
The primary difference, really, lies in the duration of the symptoms. In ASD, the individual experiences those same clusters of symptoms we see in PTSD, the intrusions, avoidance, negative mood changes, and hyperarousal. But the time frame is shorter.
Shorter how?
To meet the criteria for ASD, these symptoms must last for at least 3 days, but no longer than 1 month following the traumatic event.
Okay, 3 days to 1 month. So it's like an immediate, intense reaction that either resolves relatively quickly or, unfortunately, could evolve into PTSD if it persists past that month.
Exactly. You can see ASD as an early response to trauma, and monitoring individuals who initially present with ASD is really important to see if their symptoms resolve or if they progress to meet the criteria for PTSD after that 1 month mark.
That makes the distinction really clear. Thank you.
Mm.
Now, what about adjustment disorders? You referred to them earlier as the everyday trauma response. That suggests they're triggered by different kinds of events.
That's right. Adjustment disorders develop in response to identifiable stressors, but these stressors are often, well, more common life events. Things like relationship breakups, moving to a new city, losing a job, retirement, significant financial difficulties, stuff like that. The key characteristic is that the emotional or behavioral reaction is significant enough to cause noticeable distress or impairment in daily functioning, and it develops within 3 months of the stressor occurring.
So it's not necessarily a life-threatening event, but it's still something that throws someone off balance in a really significant way. You had an example of Sasha dealing with job loss?
Yes. Sasha, after being laid off, experienced persistent insomnia, found herself crying frequently, and withdrew from her usual social activities. These are clear emotional and behavioral changes directly linked to the job loss, and they're causing her significant distress. That illustrates a common presentation of an adjustment disorder with depressed mood.
Okay, that makes sense. Let's shift our focus now to the impact of trauma on children, specifically reactive attachment disorder, RAD, and disinhibited social engagement disorder, DSED. These sound particularly poignant, often stemming from very early life experiences.
They really are. Both RAD and DSED arise from experiences of significant neglect or maybe a pattern of frequent changes in primary caregivers during early childhood. In reactive attachment disorder, the child exhibits a persistent pattern of emotionally withdrawn behavior towards adult caregivers.
Withdrawn how?
They rarely seek comfort when they're distressed and rarely respond to comfort when it's offered. There's often a marked lack of positive affect, smiling, engagement, and difficulty forming those secure, trusting attachments that are so crucial for healthy development.
That sounds like a really fundamental disruption in their ability to connect with others. So sad.
It is, and it can have long-lasting effects on their relationships down the line. Disinhibited social engagement disorder, DSED, on the other hand, can present quite differently, almost the opposite in some ways.
Uh,
Children with DSED often show an inappropriate level of familiarity and willingness to go off with complete strangers. They might approach unfamiliar adults readily, initiate conversations, and even physically interact with them, like hugging, without showing typical wariness or boundaries.
you had an example of a foster child illustrating DSED.
Yes, a young foster child who, upon arriving at a new foster home, immediately runs up and hugs a complete stranger at a park outing. While on the surface it might seem like just friendly behavior, in the context of a history of neglect and multiple caregiver changes, this lack of discrimination in forming attachments can be a key indicator of disinhibited social engagement disorder. It reflects a disruption in the normal development of attachment behaviors.
It's sobering to consider the lasting impact of those early childhood experiences on attachment and social development.
Mm.
Okay, now let's delve into what we understand about why these disorders develop. You mentioned etiology and some theoretical perspectives. What are the key biological and psychological factors at play here?
Well, from a biological perspective, research has highlighted several areas of the brain and body that can be affected by trauma. The amygdala, which is central to processing emotions, particularly fear.
Right, the fear center.
Exactly. It often shows increased activity in individuals with trauma-related disorders. Conversely, the hippocampus, a region crucial for memory formation and learning, has sometimes been found to have reduced volume.
Smaller hippocampus.
In some studies, yes. Additionally, the hypothalamic pituitary adrenal axis, the HPA axis, which regulates the body's stress response through hormones like cortisol and norepinephrine.
It's a stress hormone system.
Right. That can become dysregulated. It might lead to either over or underproduction of these stress hormones.
So it's not just a psychological response. There are actual, tangible biological changes that can occur.
Absolutely. And alongside these biological factors, psychosocial elements are also critical. For instance, individuals who experience trauma during childhood may have an increased vulnerability to developing trauma-related disorders later in life.
That makes sense. Early experiences shaping later life.
Mm-hmm. But on the other hand, having strong and supportive social networks can act as a significant protective factor. Good support can help buffer the impact of traumatic events and promote resilience.
That really underscores the importance of connection and support in navigating difficult experiences. You also mentioned cognitive theory in relation to trauma. How does that framework help us understand these disorders?
Cognitive theory suggests that traumatic experiences can essentially shatter an individual's fundamental beliefs about themselves, the world, and their sense of safety and control.
Like your whole worldview gets broken.
Exactly. These shattered beliefs can lead to persistent negative thoughts, feelings of helplessness, and a sense that the world is inherently dangerous. This altered cognitive landscape can then contribute to the development and maintenance of trauma-related symptoms. It's like the trauma forces a rewrite of their core assumptions about life.
That makes a lot of sense. If your fundamental sense of safety is gone, it would understandably color your entire perception of the world. Okay, so let's move on to treatment. What are the primary ways we help individuals who are struggling with these disorders? Let's maybe start with pharmacological interventions, the medications.
Sure, medications can play a valuable role in managing some of the specific symptoms associated with trauma-related disorders. Selective serotonin reuptake inhibitors, SSRIs.
Like Prozac, Zoloft.
Exactly, like sertraline and paroxetine. They're often considered first-line medications for PTSD. They can help with symptoms of anxiety, depression, and those intrusive thoughts.
Okay.
Serotonin norepinephrine reuptake inhibitors, or SNRIs, like venlafaxine, can also be effective, particularly in addressing symptoms of hyperarousal and maybe emotional numbing.
And what about those really distressing symptoms like nightmares that can severely impact sleep? Is there anything for that?
Yes, for PTSD-related nightmares, prazosin, which is an alpha-adrenergic blocker, has shown effectiveness in reducing their frequency and intensity.
Okay, good to know.
And beta blockers like propranolol can sometimes be used to help manage the physical manifestations of anxiety, like a rapid heartbeat or tremors, especially if someone anticipates an anxiety-provoking situation. In more severe cases where individuals experience significant agitation or maybe even psychotic-like symptoms alongside their trauma reactions, antipsychotic medications like risperidone might be considered, usually off-label and in conjunction with other therapies.
You made a really important point earlier about benzodiazepines like Xanax or Valium. Could you just reiterate why they aren't typically the first choice for these disorders?
Yes, it's a crucial point. While benzodiazepines can provide short-term relief from anxiety, They are generally not recommended as a first-line treatment for trauma-related disorders, especially PTSD.
Why not?
Well, they carry a significant risk of dependence and tolerance, and perhaps more importantly, they can actually interfere with the brain's natural processing of traumatic memories, potentially hindering long-term recovery.
Oh, wow. So they might make things worse in the long run.
Potentially, yes. And this risk is amplified in individuals with a history of substance use, which is unfortunately not uncommon in those who have experienced trauma.
That's a really important caution. Okay, so alongside medication, what are the main types of psychotherapeutic interventions like talk therapy that have been shown to be effective?
There are several evidence-based psychotherapies that are considered highly effective. Trauma-focused cognitive behavioral therapy, or TFCBT, is a specific type of CBT that directly addresses trauma-related memories, thoughts, and feelings.
Okay.
It helps individuals, particularly children and adolescents, to identify and challenge distorted or unhelpful beliefs related to the trauma and replace them with more balanced and realistic ones.
And what about EMDR? It seems to be gaining more recognition in the treatment of trauma.
Yes, eye movement desensitization and reprocessing, or EMDR, is another well-established and effective therapy for trauma. It involves the client focusing on traumatic memories while simultaneously engaging in bilateral stimulation.
Like following the therapist's finger.
Exactly, like following finger movements with their eyes or sometimes using tapping or sounds. While the exact mechanisms are still being researched, it's believed to help the brain process and integrate traumatic experiences in a less distressing way. It reduces the intensity of emotional reactions to those memories.
That's fascinating. And you also mentioned prolonged exposure therapy.
Yes, prolonged exposure therapy involves a gradual and systematic approach to confronting trauma-related memories, feelings, and situations that the individual has been avoiding.
Confronting them. How does that work?
By repeatedly and safely engaging with these avoided triggers, both in imagination and sometimes in real life, the therapy helps to reduce the fear and anxiety associated with them. It ultimately helps break that cycle of avoidance that often maintains the disorder.
That sounds like it could be quite challenging for the individual, but ultimately maybe very liberating.
It can be emotionally demanding, definitely. But with the guidance and support of a trained therapist, it can lead to significant reductions in PTSD symptoms and improved quality of life. And finally, group therapy can also be incredibly beneficial.
How so?
It provides a supportive environment where individuals who have experienced similar traumas can connect with others, share their experiences, build a sense of community, and reduce feelings of isolation and shame. Support groups specifically for veterans or survivors of certain types of trauma can be particularly powerful.
That sense of shared understanding and not being alone in the experience must be incredibly validating and healing. Now, shifting our focus specifically to nurses, what are some of the key considerations and approaches they should keep in mind when caring for individuals who have a history of trauma?
Oh, trauma-informed care is absolutely essential in nursing practice. The first step is always assessment, and this involves sensitively and respectfully taking a trauma history,
Gently.
very gently, being mindful of potential triggers during the conversation, and thoroughly assessing for the range of trauma-related symptoms. Also assessing for any risk of suicide or self-harm, and evaluating the individual's available support systems.
And what kind of nursing diagnoses might be particularly relevant when working with this population?
Several nursing diagnoses might be appropriate, depending on the individual's specific presentation. Things like post-trauma response, maybe disturbed thought processes, ineffective coping, risk for suicide, feelings of powerlessness. The key is always to tailor the diagnosis to the individual's unique needs and challenges.
Mm-hmm. And in terms of practical interventions, what are some key things nurses should focus on in their day-to-day care?
Creating a sense of safety and predictability is paramount. Maintaining a calm and consistent approach, clearly communicating procedures and expectations, establishing a structured environment. All that can help reduce anxiety and promote trust.
Building that trust seems crucial.
Fundamental. Building a strong therapeutic relationship based on empathy and respect is absolutely fundamental. Nurses can also play a crucial role in helping individuals identify their specific triggers, working towards developing strategies to avoid re-traumatization within the healthcare setting itself,
Yeah, that's important.
and teaching essential grounding techniques to help manage overwhelming emotions in the moment.
Grounding techniques like helping someone come back to the present when they're feeling overwhelmed by the past. You shared a specific example earlier, the 5-4-3-2-1.
Yes, exactly. The 5-4-3-2-1 grounding technique is a simple yet powerful tool. It involves encouraging the individual to name 5 things they can see right now, 4 things they can physically feel, 3 things they can hear, 2 things they can smell, and 1 thing they can taste.
Using all the senses.
Right. It engages their senses and helps to anchor them in the present moment, interrupting that flood of distressing thoughts or feelings.
This sounds like a really accessible and practical skill that nurses can teach. What about the importance of educating the client and their family about trauma and its effects?
Education is absolutely vital. It's crucial to reassure individuals that PTSD and other trauma-related disorders are real, diagnosable, and importantly, treatable conditions.
Hmm.
Normalizing their reactions to trauma, saying something like, what you're experiencing is a normal response to an overwhelming event, that can be incredibly validating and reduce feelings of shame or feeling like they're crazy.
Yeah, taking away that stigma.
Exactly. Nurses also play a key role in teaching healthy coping skills, developing personalized safety plans, and, when appropriate and with the client's consent, involving family members in the psychoeducation process to foster understanding and support.
That makes so much sense. Empowering individuals and their families with knowledge can be a huge step towards healing.
Mm,
You also shared the story of Anna, a school shooting survivor. Could you remind us of her experience and how it illustrates the potential for recovery?
sure. Anna, a 19-year-old survivor, developed significant PTSD symptoms after the shooting, recurring nightmares, intense avoidance of her college campus, being easily startled by loud noises.
Hmm.
Through a combination of EMDR and CBT therapy, Anna gradually began to process her traumatic experience. Over time, she experienced a reduction in her nightmares and anxiety, felt safer returning to her college classes.
That's great progress.
It really was, and ultimately she found strength in her experience, becoming a peer mentor for other students who had experienced trauma. Her story is just such a powerful reminder that healing and recovery are possible, even after profound trauma.
Anna's story is truly inspiring and offers a lot of hope. So, as we bring this deep dive into trauma and stressor-related disorders to a close, what's the most important message you'd like our listeners, especially those stressed students, to take away?
Ultimately, I think developing a deep understanding of the multifaceted impact of trauma is fundamental for providing truly compassionate and effective care. Recognizing the diverse ways trauma can manifest, from PTSD to adjustment disorders, the attachment issues in kids, it enables nurses, enables you to approach each individual with greater empathy, tailor interventions more effectively, and foster hope for recovery.
Absolutely. It's a powerful reminder that behind every symptom, there's often a story of resilience and an incredible capacity for healing. Hey, to all of you tuning in, especially if you're navigating the intense world of nursing studies or just feeling the weight of understanding these complex mental health topics,
Yeah.
remember that taking this time to learn and grow is a testament to your dedication. You're building the knowledge and empathy that will make you truly exceptional caregivers. Be patient with yourselves as you navigate this important material. And remember, you've absolutely got this.
You do.
Take care of yourselves, maybe do a quick mental health check-in, and we'll catch you next time.